I'd like to welcome a very special guest, Dr. Jose Almeida, serves as a voluntary professor of surgery at the University of Miami School of Medicine, sits on the American Venous Forum Board of Directors, and is the chairman of the Society for Vascular Surgery Patient Safety Organization Venous Quality Committee. He's authored numerous peer-reviewed journal articles for years and textbook chapters on vascular surgery and sits on the editorial board of the JVS VNL. For the last 20 years, he has chaired the International Vein Congress and is an author and editor of the Atlas of Endovascular Venous Surgery textbook. Welcome, Dr. Almeida.
Thank you, Anil. Thanks for having me.
So, November 16th and 17th, you're going to be the chair of the Venous session at V. What is this session about?
Yeah, thanks. So maybe a little background as to why this is such a big deal. So Frank Veith, we all know him, iconic vascular surgeon, storied background as a transplant surgeon. And so this meeting is now in its 50th year. I mean, how many meetings do you know that go on 50 years? And Frank Veith is 92 years old. And if you know Frank Veith, the guy is sharp as a tack, full of energy. I've never met a guy like this. So, for a meeting to go 50 years, it takes a lot of work and energy. And that just, epitomizes Frank Veith. So, um, and I personally have been going and speaking the meeting for over 20 years, but about 18 years ago, he wanted to do a dedicated venous section as this endovenous revolution was taking off. So he asked myself and Lowell Kabnick to create and chair this session, which initially was one day, and it was sold out. And then fast forward now, it's a full 2 day didactic session plus an additional day of some workshops and even a newer section of guidelines that your partner Enrico Asher has developed. So, 18, 19 years of a dedicated Venus section that's grown to I don't know how many talks. It is typical of V style, 5 minute PowerPoints. Uh, and I personally like that because it really forces the speaker to just drill down to the take home points. Um, it is, I don't want to say it's a meeting for advanced people, but it's serious people that go to the meeting, both on the arterial side and the venous side. He has something for everybody. He's got all kinds of side sessions, international sessions, sessions for residents and fellows. So, I mean, it's quite an event. I look forward to it every year, third week in November in New York City. For a Florida boy, go get your little cold weather. It's great. So, uh, Venus is the name we gave to the dedicated Venus section. So, Wednesday of the meeting, again, there's a workshop and a guidelines section. Thursdays where it really kicks off the plenary or general session in Venus. And the way we have it sort of divided is Thursday is superficial vein disease, Friday is deep vein disease. It flows well. Superficial vein disease, endovenous technologies just took over 20 years ago. You're very familiar with them. I think that was a spark for this meeting. Endovenous laser ablation, radiofrequency ablation, how to manage these things in the office versus a hospital. That whole roll up for the last 10 years. And now we're at all the nuances, all the things that happen, all the non-thermal devices that are developed to mitigate having to place domestic anesthesia, phlebectomy techniques. There's non-saphenous techniques like Chiva and Asval, where you try and preserve the saphenous. I mean, there's a lot out there. It's a lot. And this is just a superficial. So, as far as tracking devices, as we know, endovascular in general is very device centric. Aortic aneurysms with endovascular aortic aneurysm repair, thoracic aneurysms. Well, veins are the same thing. So superficial veins, endovenous devices, took it from the hospital to the office. Next came venous stents for iliac vein obstructive disease. No longer big bypasses of the iliac veins that don't work. We can do endovascular techniques now for the vena cava, for the iliac veins. Vena cava filters can now be removed. Filters that had to be removed within a month, there's no way to get them out. We take them out, they've been in there for 20 years now. We have a new laser that was originally developed for lead retrieval that we can now use for filter removal. We can recanalize atretic vena cavas with wires, sexy balloons, and line them with some nice dedicated venous stents. And then probably the most recent technology to really enter are the mechanical thrombectomy devices for deep vein thrombosis. So previously it was surgical procedures, extracting thrombus, and then came the lytic era where medications like tissue plasminogen activator are used to dissolve clot. These came with bleeding risks and bleeding complications, some of them disastrous. So the field has moved from lytic to just straight mechanical thrombectomy. And there's a bunch of devices that are available. These are in the meeting. We have experts from around the world discussing these things. So really, it is quite broad, superficial, deep vein stenting, and pelvic vein embolization with ovarian vein type reflux disease, and clot management. Of course, there's medical clot management and interventional. Um, and let's not even forget. So I always take it from C1 to C6 disease, C1 being little cosmetic spider veins to C6 being ulcers. So C1 disease, injecting spider veins with sclerotherapy, cosmetic stuff. We discussed that all the way to venous ulcers, which are horrendous, wound care and require a lot of venous work and bandaging techniques and everything in between. So venous disease is grown, as you know. You've been there with it. You've sat with me on many of these committees, and we just finished the new guidelines. So all that is discussed at VEITH, and that's what VEITH is all about.
So, what's something new at this particular session this year?
Um, New, I guess it would be uh, iterative this year more than new and disruptive. Um, what I've described, just now as we got into the different eras, superficial to deep stents to thrombectomy, I thought the devices were truly disruptive at that point. Now it's really iterative, so tweaking the new devices about nuances. I think a lot of it will be uh, guideline, really putting the guidelines out to this year. So, for example, uh, our entire field was critiqued by the MedCAC committee several years ago that the evidence was poor, which is true. But as you know, this undertaking, as of late, on the Part 1 and Part 2 varicose vein guidelines, uh, sponsored by Society of Vascular Surgery, American Venous Forum, AVLS, of course, Peter Glavitsky was the energy behind it. We now have a new compilation of evidence. The last ones were in 2011. Now we're 22, 23. So I think what that is doing now is now we've got all the clinical trial data, randomized trials, observational studies. We have a real evidence-based approach so that now when we discuss these technologies, we have some studies behind it. And so, for example, let's just talk about clot extensions at the saprophymal junction after thermal or non-thermal ablation. Uh, there was an old name for a long, long time called EHIT. Now there's new names. and more data on how to manage it. So, do you need an ultrasound after superficial vein ablation? I think most of us did it routinely, and new evidence to suggest now that in asymptomatic patients that are of good risk, not high risk medical patients, there's no need for an ultrasound. So that's a cost savings to the community. So that'd be an example on the superficial side. On the deep side, we're really now tweaking how to use these dedicated venous stents, how to really place them correctly at the cable confluence. We don't have to project into cava anymore and jail the other side. There were issues with, for example, short stents landing at the SI joint that they kind of start stepping off. Now we've learned that, well, you should probably extend it through the SI joint, land it in the extracerebral vein. There were stent embolization issues as the new stents were rolling up. I think we've gotten our arms around that a little better with proper sizing now, using intravascular ultrasound, proper length, how the dedicated nitinol stents differ from traditional wall stents. So we've learned a lot there. The clinical trials have, now rolled out to 4-year data. So that field is maturing. Pelvic veins are really now forming. This was called pelvic congestion syndrome, this sort of vague, mysterious disease of women with, low pelvic pain and, what to do with them. And then we got into uh, you know, nutcracker, so renal vein compression, ovarian vein reflux, and iliac vein compression, all in this little box. And which one is more important than the other, and how you sort them out, and how you treat them, and how you back to these women. Now it's under the leadership of Mark Meisner, who will be their pelvic vein disorders. It's a new classification system. We have a better understanding of it. I think we got a better sense of who not to treat, who to treat, how to treat them. Still a long way to go with pelvic vein disorders, but at least that's taking shape. With clot management, we've gone away from warfarin. We have direct factor 10 inhibitors. There's a solid data behind that now. When to use them, how long to use them. Pulmonary embolus management is also in the meeting. New technologies for removing thrombus out of the pulmonary arteries, which can be life-saving. PERT committees. The list just goes on and on. So to really name all the new things, there's so many talks and sessions, and all the speakers that are pretty much world renowned have their own little interpretation of the data mixed with their experience and how they do things. So I'm looking. I always learn. I mean, I leave there and I learn something, a lot of things. So I'm excited.
I actually agree with you. Every time I come back from the meeting, I always have new ideas, new things I want to try or new things I want to investigate. So it really, really generates a lot of investigative activity, but also really clinically useful activity that really is unparalleled with, especially with the sheer number of talks that you have there is really high powered, short, fast, concentrated, and well directed. So, and patient centered. So I think that's all very,
Yeah,
very important.
it's a clinical meeting. The other nice thing that VEITH on demand. So, and this is important for this meeting. So, if you're not expected to sit through all the sessions. I mean, there's so much going on. 6 a.m. to 6 p.m. 5-minute talks. Hundreds of them. So the what goes on in the hallways outside of the meeting rooms, all the seeing people, now that we're out of COVID, shaking hands, face to face, conversations. Hey, did you hear that? What are you doing now? This is new at the bar over a drink. The more stuff comes out. That's all part of this. And if you can't hit all the talks, well, in a few weeks later, you got all the recorded sessions on Beat on Demand. You can go at them at your own leisure and pick out any little details that you may have missed because you missed a talk. So uh, joining with colleagues, as you know, it's a huge faculty. I don't know, it's over 120, 130 faculty there. So who's who, in the community, all of the vascular world is there, arterial and venous. Of course, our focus is venous. So that's part of it. Networking with colleagues, seeing what's going on, going out to dinner with folks, shaking hands, seeing what folks are working on. It's all part of it. So it's all part of the VEITH experience.
Who should attend this Venus session?
Anyone interested in venous disease? So, as you know, and so SVS, American Venous Forum, I think it's fair to say they were good old boy clubs in the past. Vascular surgeons, academic university types, and community didn't feel welcome. That's all pretty much changed. Not only is it not only exclusive to vascular surgery. There's some interventional people that attend interventional cardiology and radiology, vascular medicine. I'm not sure how many medical people, but at least a broad array of interventionalists, not just surgeons. And industry people attend. We see them in the sessions, or folks working on devices, industry engineers. They like to speak to the speakers in the hallways. There's a lot of side meetings set up with industry. Hey, what are you working on? Can you give us some ideas? I heard this talk over there on this stent with this chronic outward force, and I heard these problems. How can we solve those problems they were talking about? Can we work together? A lot of that stuff goes on. So, industry is a big part of it. The exhibitors, some of them have these big pavilions and do their own events like lunches, and they'll usually have speakers. Those are non-CME, so a little more, biased towards the sponsor, obviously. But at least you get to interact with the people that make the devices and really get the history behind the device. Usually, they're very forthcoming on problems they may have had in the device development pathway, or looking for ideas to make things better for patients. So industry, we can't leave them out. They're a big part of it, and they're all there exhibiting.
Great. I want to thank you. This sounds like a really great session. Again, it's going to be November 16th and 17th at V 2023 in New York City. Dr. Almeida, thank you so much. This was really a lot of fun. I really enjoyed it.
Yeah, thanks, me too, and we hope to see everyone there. It doesn't matter where you're from, international, U.S., come on over and learn about venous disease.